and my gratitude to Nikhil for having me in this really well thought out IC. And I'm sorry for not being there in the hall right now in person. I'll be talking about corneal biomechanics in cornea and refractive surgery. And to begin with, I'll talk about why we really need it. Now, we know that the cornea is not a piece of plastic. It exhibits the properties of viscosity and elasticity. And why is this important? Why do we need to know about these properties? That is because changes in these properties happens before morphological changes appear on tomography. So if we are able to detect a weakness in these properties early on, we can actually prevent the development of ectasia. And how do we measure corneal biomechanics? There are two commercially available instruments for that. The first is called the Ocular Response Analyzer, which uses a bidirectional applanation force and measures two important parameters called the corneal hysteresis and the corneal resistance factor. You see both these parameters being low in an individual who has a biomechanically weak cornea, which is somebody with keratoconus in this case. The limitation of this instrument, however, was that it was not sensitive enough to detect fine biomechanical weakness by itself, and it needs to be complemented with other diagnostic modalities. Also, the exact correlation of these parameters with the true measure of the Young's modulus is still not known. The relatively newer instrument called the Orvis ST is also gaining a lot more functionality now because there are a lot of updates that have been coming. So this uses a air puff induced deformation, which is tracked by a Scheinflug imaging device, which captures multiple cross-sectional images of the cornea. The parameters that you get in this includes things like deformation amplitude of the cornea, deformation amplitude ratio, and the radius of curvature. So in an individual with keratoconus who we know has a biomechanically weak cornea, you'll see a quicker first applanation happening, you'll see greater deformation amplitude, and also you will see a delayed corneal recovery in these patients. How is this relevant and how do we apply this? So if you have a patient like this, you see the tomography which appears relatively normal, except the fact that it's a thin cornea. So you would consider a surface ablation in this otherwise, but when you take into account the biomechanics here and you see that the deformation amplitude and other dynamic corneal response parameters are impaired as well, you would rather stay away from this case because you're definitely putting this patient at risk by doing any form of corneal laser vision correction in her, because it's not just the tomography being thin, but also the biomechanical parameters being abnormal. This, on the other hand, is again a slightly thin cornea, 500 microns, but when you look at the biomechanical parameters here, they're quite good, which indicates that this is a strong cornea and therefore a lot less likely to develop ectasia in the future. So you can definitely consider LASIK in this case and not just surface ablation. So with these different dynamic corneal response parameters, there was definitely value added, but it was felt that there was need for some normative data. So you can compare these parameters to the normal population. So this was provided by the Vinci Guerra screening report. And apart from this, this also gave us the Orvis Biomechanical Index, which was developed using a linear regression analysis, uses some of the dynamic corneal response parameters that I spoke about. Apart from that, also uses a stiffness parameter and the horizontal corneal thickness profile. So this has been found to have a pretty high sensitivity and specificity in detecting cases of keratoconus. Following this, it was felt that there was a need to be able to integrate biomechanics with tomography. And that's where the tomographic biomechanical index came into play and was found to be useful. This has been found to have the highest sensitivity for detecting subclinical or formifraste ectasia. So what you see here on the right is a patient with a relatively normal looking corneal tomography, a pentacam scan. You can see that the BAD-D is also quite normal. But when you look at the tomographic biomechanical index, which is taking into account the biomechanics as well as the tomography, you see that the value is quite high, which indicates that this is definitely not somebody with a healthy cornea, and you would rather avoid any form of laser vision correction in this patient because this individual is at the risk of developing ectasia later on whether you do the surgery or not, but definitely more so if you end up doing a corneal laser vision correction in this particular patient. Now, I'll talk about some of the newer indices of corneal biomechanics. One of these is the stress strain index. The stress strain curve basically is not very relevant when you look at multiple individuals at one time point. This is relevant when you compare the same eye over different time points. So, if this curve is moving to the left, that means the cornea is becoming stiffer or stronger. Whereas if it is moving to the right, that means the cornea is becoming softer or weaker. The stress strain index is what describes the position of this curve. So if this value is more than 1, that means the cornea is showing stiffer behavior. Whereas if it is less than 1, that means it is showing softer behavior. And this is one of the first parameters that has been accurately able to indicate stiffening or strengthening after cross-linking. None of the other parameters were able to do that. The final index that I'll talk about is the CBI LVC, which is basically able to automatically detect whether the examined patient has a treated cornea, that is, has the individual undergone a laser vision correction. Now, when you look at the other parameters in these corneas, everything is going to be abnormal. So you don't really get much of an indication on the possibility of development of future ectasia in patients who've already undergone laser vision correction, whereas this particular index is able to do that. So it is able to differentiate stable eyes post laser vision correction versus eyes that are at risk of ectasia or have developed ectasia after laser vision correction. So to summarize, corneal biomechanics has definitely added a new dimension to our ability to detect keratoconus, and also in our ability, or also in our pre-operative screening for refractive patients, to detect the possibility of these patients developing ectasia later on. And corneal biomechanics combined with tomography is definitely the way to go. It has significantly increased our sensitivity and specificity in detecting ectasia and being able to predict ectasia. Thank you so much. Thank you for having me here.
Uh, Thank you, Tushar. That was really a lovely talk, explaining the evolution of biomechanics over the years. I would like to ask a question to one of our panelists. Dr. Pavitra has worked extensively with the Corvis. I would like to take her opinion whether, as a refractive surgeon, is it absolutely essential in majority of the cases, or is a pentacam a device like that which gives you both the anterior and the posterior float good enough with the bad D to predict whether a patient post refractive surgery should be taken up for if a patient should be taken up for his refractive surgery or not?
So, from my personal experience, I feel that only in suspicious cases where we have doubt, wherein whatever few parameters, if they are in not very normal zone, in those particular cases, biomechanics will definitely have a very important role to play, but not for all the normal cases. So, I think in suspicious cases, it will have a role.